Dr. Palta is an associate professor in the Department of Radiation Oncology at Duke University. She's an expert in the treatment of GI malignancies, and she's going to teach us about the treatment of pancreatic cancer.
So we were laughing a little bit because we weren't sure which order the slide deck was going to be in because we had a little bit of discrepancy about who was going first, so we just thought we'd wing it and see. Dr. Holliday said she is often at the end of any sort of conference day, so here we are. And again, I'm sorry.
It's all good.
So I have the difficult task in 20 minutes of talking about how we should be using radiation in the treatment of pancreas cancer. And I could focus on lots of retrospective data, which is where the bulk of the data are, and there are not a lot of prospective studies. So taking a talk that was actually an hour and moving it into 20 minutes, I think actually worked out just fine. But you guys can be the judge of that. So there's two objectives that we'll talk about. We will talk about or define the role of radiation in the neoadjuvant management of pancreas cancer. We'll also talk a little bit about the available information that we have on dose, fractionation, concurrent chemo versus not in the management of these patients. So I like to start with a case presentation, and I have a lot of imaging data here because I find, especially with trainees in the audience, one of the most challenging things about pancreas cancer is actually the imaging. And I rely on our radiologists a lot as we're defining resectability. So this is a 53-year-old male with painless jaundice, dark urine, who presented to the ED and ultimately had a pancreatic protocol CT. And here are a couple of images here. Things I like to point out is the vasculature, right? Because the most important thing about pancreas cancer in terms of defining resectability is how closely associated that tumor is to various vasculature. So here, outlined in these axial images, you can see the portal vein, abbreviated PV, the IVC, and the aorta. And we'll continue going from the top down, and I've just tracked these vessels so you can see here's the portal vein, shooting off the common hepatic artery, the portal vein, as well as the celiac axis. And you can start to see here the pancreas with a little bit of dilated duct. Continuing to go down, celiac axis. And then we get to the point where the tumor is. And what often happens with, well, not often, but sometimes happens with these tumors is that you get a little bit of cystic blowout, or you get a little bit of a cystic fluid that happens because of the dilation of the duct or obstruction of the duct. And here you can see some of the tumor associated with the portal vein. And as we go further down, that then becomes the SMV, tumor associated there. Pointed out tumor in case you weren't sure exactly where it is, which sometimes is challenging. Again, the importance of having radiology colleagues to help in defining exactly where these lesions are. Tumor associated with SMV, and you've got a little bit of a hair going towards the SMA, which is what then categorized this as a borderline resectable cancer. And then into normal pancreas inferiorly. So this slide here is not for you to visualize or to be able to read all of it, but really just to point you to the fact that probably the most commonly used criteria for resectability comes from the NCCN criteria. That is the guidelines that we use at our institution for defining resectability. And so because there was involvement, just a touch of involvement of the SMA, as well as broad contact with the portal vein confluence, that is what categorized this into the borderline resectable category. So there's lots of reasons that we should think about neoadjuvant therapy. If we look at long-term outcomes from pancreas cancer, the vast majority of people are going to develop metastatic disease. So what is the purpose of neoadjuvant therapy? So the first thing has really not a lot to do with radiation, but more to do with systemic therapy, is that we're able to address that micrometastatic disease much earlier on in the patient's disease course, and therefore we can more accurately select those patients that are going to likely benefit from surgery the most, particularly if that surgery involves a Whipple operation, which is a life-altering rotor-rootering of plumbing with multiple anastomoses that are created. The other reason that we think about this, and this is where radiation starts to fit in, is we have to think about the fact that there are high rates not just of distant disease recurrence, but also local recurrence. And I mentioned this already, but this patient selection or testing biology is an important consideration for pancreas cancer. And we know that even in the modern era, so we used to think local recurrence in the neighborhood of 50% based on a much older series. This is data that was published more recently, so this is from the SPEC4 study, It's not a chemotherapy regimen we often use now, which is gemcitabine, but what it does highlight is even in the modern era with modern day imaging, modern day surgery, we're still seeing local recurrence rates in the neighborhood of about 50%. And this is an important problem, particularly as our systemic therapy gets increasingly better at addressing that distant metastatic disease. So as we think about kind of clear reasons for why we should think about radiation in this setting, the things that I sort of have boiled out and I'll talk to are 3 areas of why radiation in the neoadjuvant setting is important. It results in higher rates of R0 resection. It is associated with better compliance with radiotherapy, which is true, honestly, throughout all areas of oncology when we think about neoadjuvant therapy compared to adjuvant therapy. And typically the toxicity is less. So I'll show data to these 3 points. So radiation results in a higher rate of R0 resection. So I love this slide because it shows that just like radiation is not black and white, thinking about resectability also is not black or white. Even though, according to NCCN criteria, we bin people into categories, what I like about this figure is it illustrates that really there's a continuum of resectability from clearly unresectable to resectable, but with varying gradations across the way. So if we look at R0 resection rate, and what this table summarizes is the data for adjuvant therapy across the board. So these are trials that were conducted from 1998 with the CONCO study up to more recently the PRODIGE study, which looked at the use of adjuvant FOLFIRINOX. And if you look at all of these trials and the associated rate of R0 resection, what we see is in general that R0 resection rate is about kind of 60%. There are some fluctuations, so that is in the 4th column over. And we know that R0 resection rate is important. So this is going back to that SPEC4 study. And what we see is that regardless of if patients got gemcitabine or they got the combination gemcitabine-capecitabine, that there was an improvement in overall survival simply based on R0 resection. So it just highlights the point that R0 resection rate is clearly important. So I will talk a little bit more about the PREOPANC study in a minute, but I'm just illustrating the point of a couple of points of why neoadjuvant therapy in this setting is important. So in the PREOPANC study, which is a comparison of upfront surgery versus upfront chemoradiation followed by surgery, what we see is higher rates of R0 resection, closer to 70%. There's also an Asian randomized trial that didn't quite complete accrual, but again, provides some of the prospective data that we have looking at upfront surgery compared to a chemoradiation approach followed by surgery, also showing higher rates of R0 resection. When we give radiation in a neoadjuvant setting, it is also associated with higher rates of compliance of therapy. So again, a summary slide of the data that I showed. These are the adjuvant therapy trials. And across the board, as we look at completion rates of adjuvant therapy, we see that rate's, again, about 60%. This is true in pancreas cancer. This is true in head and neck cancer. It's really kind of true across the oncologic spectrum when we look at adjuvant therapy. If we look again at the trials incorporating neoadjuvant therapy, so I mentioned the PREOPANC study, so completion rate closer to 75%, so clearly better than if we're giving treatment adjuvantly. The Asian randomized trial, again, small numbers, but 96% rate of completion. And I just contrast this with the SWOG study, which is not at all a radiation study, but is just looking at neoadjuvant systemic therapy. And we see similarly higher rates of therapy completion, even if we're just giving systemic therapy by itself. Giving radiation in a neoadjuvant setting is also associated with lower rates of toxicity. So not just increased compliance, but also lower rates of toxicity. And it could be that because there's lower rates of toxicity, that's what results in the improvement in compliance. So compliance, this is looking at some of the neoadjuvant studies that have this data published and available. So in that PREOPANC study, which is a comparison of upfront surgery versus chemoradiation, the rates of grade 3 or higher toxicity were less than 50%. If we contrast that with the RTOG study, which was a study of adjuvant chemo and chemoradiation, Those rates are much higher at 60, 80%. And if we look at the PRODIGE study, which is not at all a radiation study, but just looking at adjuvant systemic therapy, we see grade 3 plus toxicity in the neighborhood of about 50 to 75%. So lower rates of toxicity generally with a neoadjuvant approach. So let's now pivot a little bit towards understanding dose fractionation and talking about concurrent regimens. So there's a lot of data here, and I am only focusing on prospective data. And what I'm hoping to prove to you is that you can really do any dose fractionation, chemo, no chemo, SBRT, concurrent chemo RT. Really, there's data to support anything you want to do. But I will talk about the data that I think is best supported by phase 3 information. All right, so conventional fractionation. So we don't have a lot of great data in this space, but yet this is probably the mechanism or modality of treatment that we often do. And so this just highlights, again, one of the sole prospective studies that we have in this space of borderline resectable disease, which was conducted by the Alliance, which is a single-arm study. 23 patients in total, all got some FOLFIRINOX, and then all received chemoradiation. Important things here is that it was conventional fractionation to 50, 40, and 180 centigrade per fraction, either 3D or IMRT. And then I like to often note what volumes look like, because I think that this is sort of the details that don't get kind of highlighted quite as much. So in this trial, it was really not full elective nodal treatment. It was treatment of the primary tumor and any abnormal nodes. So smaller volume fields, but again, conventional fractionation. And it's single arm, so all we can say is that this was a well-tolerated regimen. The R0 resection rate was in the neighborhood of about 80%, so quite good. And then this was sort of thought about in future trials through the Alliance. So modest hypofractionation. So this is where the pre-OPANC data comes in, and to me, this is the best data we have for supporting the use of neoadjuvant radiation. So we actually have 0 prospective phase 3 studies supporting the use of neoadjuvant systemic therapy, and we do it all the time. So this is the study when I am in tumor board and I have a surgeon, particularly a new surgeon, who says or questions the role of radiation. These are the data that I turn to, especially now with the updated data from last year showing a survival benefit, which I'll show in just a minute. So this is a phase 3 study in resectable or borderline resectable pancreas cancer, primary endpoint overall survival, and it was a reasonably sized study with 250 patients. Half were randomized to upfront surgery, the other half to upfront chemoradiation followed by surgery. And in this trial, it was designed a little while back, so if you look at the details, the adjuvant therapy was gemcitabine. We now know that based on the PRODIGE study that we should be giving triplet therapy if we can, which would be FOLFIRINOX. And in the radiation arm, it was neoadjuvant chemoradiation, so 36 gray and 15 fractions, and it was given with concurrent gemcitabine. And the volumes included the tumor and abnormal nodes, so no elective nodal treatment, so relatively small volumes. And in the initial publication and presentation, they talked about how there was a disease-free survival benefit, but in the most updated version of this data, which our surgeons don't actually know a lot about or don't see, and it's important for us to advocate this and talk about it in our tumor boards, is we now have in the updated JCO publication a clear trend towards improvement in overall survival in those patients that are getting neoadjuvant chemoradiation compared to upfront surgery. All right, a hot topic, which is ablative radiation. So these, again, I said I was going to focus not on retrospective data, but just the prospective data. And unfortunately, this is the only prospective data we have in that space, which is the Alliance trial. So this trial is sort of the bane of my discussions in tumor board, because our surgeons will often say, well, you want to do ablative radiation, but this trial is a negative trial. And I actually did a full hour-long talk about the devils in the details related to this study, but I won't share that today. I'll share with you the highlights in the next 30 seconds. So what this trial was a randomization Arm A was a full systemic therapy arm. So you can see there's FOLFIRINOX, there's restaging and more FOLFIRINOX followed by surgery. In the second arm, which is Arm B, there is systemic therapy, followed by radiation, which is there in that kind of lighter blue color. So I think this is a very thoughtful design. There is restaging at multiple time points along the way. However, the way this trial was designed is that the overall endpoint was to look at 18-month overall survival. However, at the interim analysis, which was when 30 patients were accrued to each arm, rather than looking at overall survival at that time point, what they actually looked at as a surrogate was R0 resection rate. And what they ultimately saw is they powered it or said that if at the interim analysis, the R0 resection rate in either arm was less than 60%, that arm was going to be closed for futility. And in Arm B, when they met that metric of 30 patients, the R0 resection rate was lower than 60%, and thus that arm was closed. And really all we have information about is Arm A, or at least in my mind, meaningful information. The other thing that people don't talk too much about in the trial design is that in patients who develop distant metastases, which we know is a very common situation for pancreas cancer, for that early time point of R0 resection rate, let's say a radiation patient or a patient randomized to the radiation arm developed metastatic disease, well, that was actually called a margin positive resection, even though that patient may not have undergone surgery for the purposes of that interim analysis. So I think it just, again, number of caveats to that trial design. This is what my surgeons show me in tumor board, is that these are the data that we have showing that radiation doesn't work. And I've mentioned now numerous caveats of both trial design and really incomplete data because we just don't have a lot of patients in that radiation arm. So I don't think that this is the death of ablative radiation. I think it's just more thoughtful trial design and selection of how it should be incorporated into treatment for these patients. So from there, I'll pivot to future directions. So I think what's really good about pancreas cancer is we do have ongoing and upcoming data that's going to be published and presented soon. To me, the data that I'm most excited about is the PREO-PANC2, which is building upon the fact that we clearly know that patients develop high rates of distant metastatic disease, and incorporating FOLFIRINOX, which is what we know is a tried and true regimen, especially both in the adjuvant setting and the neoadjuvant setting, and it's looking at overall survival. There are a couple of other smaller trials also, looking at that, which is the PANDAS PRODIGE trial. And then the Alliance data, which is actually looking at the question of whether or not we should be giving systemic therapy prior to surgical resection. And you can see those larger trials are powered for overall survival. I think there's other interesting areas, so advanced technology as well. So we've heard a lot, I think recently we've seen vendors talk about MR-guided therapy, especially adaptive planning that can happen with an MR-Linac to help hopefully reduce toxicity. There's some early efficacy data coming out as well, presented at ASTRO, likely to be presented at future ASTROs, looking at MR-guided radiotherapy as well as proton therapy in terms of reducing toxicity. And I think my next slide is not there, which is a concluding slide, which is to say I hope that in my 23 minutes I have convinced you that we should be thinking about radiation in the neoadjuvant setting because it increases R0 resection rate. There is associated lower toxicity rates when we give radiation neoadjuvantly, and better compliance with radiotherapy as well. As far as dose fractionation, there's data to guide really doing it any way you prefer. The best data, and what I tell our residents at boards, or for boards, is that PREO-PANC data, that is phase 3 data supporting the use of neoadjuvant therapy. So at least for the present time, that is the dose fractionation regimen that is best supported by phase 3 data. Thank you.
And actually, maybe if you could stay there, we'll take questions on your topic first.
Oh, okay.
Any questions from the audience? while you guys are mulling it over, I could pose one. So you mentioned you like the PREOPanc data the best, but in your practice, when you treat patients who still have a pancreas in place, what's the decision tree of which fractionation you use, conventional PREOPanc or SBRT?
Yeah. Oh, I can answer that pretty easily. So I think I don't want to say we're zealots, but I think we have preferences and biases about how we treat patients. So at Duke, we have 3 GI radiation oncologists who all practice a little bit differently. I tend to be more of an ablative radiotherapy delivery type of biased person. So I tend to do more ablative radiation, typically 5 fractions. To me, the key decision-making time, or things I think about are the anatomy. We also have a clinical trial offering ablative radiotherapy. So I think in a space where we just don't have a lot of data, clinical trial enrollment's always important. But even outside of clinical trials, my bias is for a 5-fraction regimen, recognizing though that the data may not be exactly where I practice.
Thank you, Manisha, for that wonderful talk. Now that you've committed to your preference for ablative 5-fraction treatment, I have a quick question for you.
Yeah.
What are your thoughts on the dose-escalated 5-fraction treatment, for example, which goes up to 10 gray per pop?
Yeah.
Or even the 67.5 gray regimens, which are widely being recommended?
Yeah, so I have now, rather than talking about things as SBRT, I really try to be very systematic in just the semantics or the terms that are used. So that's why even in this talk, I talk about SBRT, but really what we're talking about is ablative radiation. And so in my mind, ablative radiation can be given in 5 fractions, it can be given in 10 or 15. So I kind of think of that as being in the same spectrum. Ask me your question again. Now I've already forgotten
so
it.
So the 10 fraction, do you do anything close to that? I mean, do you have the capability, technological capability in your department?
Yeah. If I had an MR Linac, I would use that. I think, at the use and utilization and the prevalence of the MR Linac in an effort to give dose-escalated radiation, I see that as a valuable tool, particularly the adaptive portion of that. On clinical trial, the typical fractionation that's being utilized, so we have a Galera clinical trial that's open in an effort to reduce toxicity and improve efficacy. On that trial, we're often treating patients 10 gray times 5. To me, it really is a function of anatomy. So my favorite spot to treat is a body tumor where there's basically surrounded by the pancreas and kind of tucked away from any GI luminal structures. So I would say in 5 fractions, I tend to base my dose fractionation based on proximity to OARs. I think there's not sort of a general rule of thumb, but it's really about what I'm able to get away with the technology that I have and knowing the limitations of that as well. So oftentimes 8 gray times 5, certain situations, if it's a head by the duodenum, it is going to be 6.6 times 5, which we probably know biologically may not be enough. So I think it is really much tailored to the patient's individual anatomy. And then in any institution, it's really based on patient anatomy and then what other technologies you have available to safely spare OARs or to do some sort of adaptive planning to minimize dose to OARs.
All right, we have time. I think maybe if you can go quickly for those last 2 questions.
Sure, I'll be quick. As you mentioned, with the Prodige data, distant metastasis rates are falling, and I would argue local control is becoming more important. Do you see the role of radiation changing or increasing in resected patients that may not have the classic risk factors for local recurrence?
I think so. I think that when we look at the data, recurrence data, local recurrence, whether it's resectable or borderline resectable, still actually kind of hovers at that neighborhood of about 50%. And I completely agree with you. I think as systemic therapy improves and we are better and more effectively controlling metastatic disease, well, that's where our role as radiation oncologists and local regional therapy and reducing that risk of local recurrence actually becomes increasingly important. So I sort of view this as systemic therapy gets better, the role of radiation actually becomes more important. And I think probably, we don't have great data on resectable, but I think those are the patients that are most likely to benefit.
Sorry, just to follow up briefly, do you now advocate for adjuvant radiation therapy in patients that haven't historically needed it?
adjuvant radiotherapy in patients that,
So, negative margin, underwent resection, negative margins, no PNI, no nodes involved, finished FOLFIRINOX really well. Do you push for adjuvant radiation? or
yeah,
do
so
you
we
watch
as an
it?
institution, we do.
Okay.
Yeah, and that, again, is not based on prospective data, but retrospective data. And then maybe we'll have some more information as RTOG 0848 gets published. But again, it'll be in the gemcitabine era. So we can either take that data and say, oh, it supports what we want to do, or we can say, that data's antiquated now because of gemcitabine. So we'll see what those results are.
Thank you very much.
I just wanted to, nice talk. I just wanted to make a couple comments. It seemed to me as if you were saying MR-guided and proton, although unknown, is future potential positive results because of the technology. I think that's fantastic. And then just for us in our specialty, with all the hypofractionation that's going on, all the reduced reimbursement that's going on, and new technology is not adequately reimbursed, I think this is so important for us because, MR technology is not everywhere.
No.
Protons are not everywhere.
Right.
And in order for us to have more access as a specialty, stuff like this and your opinions and the potential, and for us to be able to have new technology, I think PACS and all of this kind of stuff is so important because we're getting killed reimbursement-wise with hypofractionation. And I think this is an opportunity like this to say, in our new negotiations for a new ROAPM, and there'll be something that we've got to make sure new technology is recognized for stuff exactly like you're saying, the potential's out there.
Right, absolutely. Thank you. Thank you.